Foundations of Maternal Newborn and Women's Health Nursing by Murray McKinney, Holub, and Jones. 7th edition. Chapter 9. Assessing the Fetus. Prenatal and antepartum fetal testing are cornerstones in providing contemporary obstetric care. Expansion in fetal development and pathophysiology research, innovative technologic advances, and an evolution of novel testing methods have transformed how healthcare teams diagnose fetal abnormalities, determine fetal growth and development, and establish fetal well-being. Historically, fundamental approaches were used to verify fetal life, assess fetal size, growth, and position, and quantify amniotic fluid volume. These methods, which are still used in modern obstetrics, include maternal perception of fetal movement using fetal movement counting, FMC, fundal height measurement, abdominal palpation, and fetal heart rate, FHR, assessment. Prenatal screening and diagnosis, once associated with specific high-risk conditions and invasive procedures, now incorporates analysis of the family pedigree, population screening tests, fetal genetic risk assessment, and genetic counseling. Advancement in chromosomal and biochemical markers, ultrasound, fetal monitoring, and fetal therapy have revolutionized how fetal abnormalities are identified and allow for greater accuracy in monitoring fetal condition. Prenatal screening and diagnosis. Women are often concerned about fetal health and well-being. Fortunately, 21st century pregnancy care has brought a variety of new and updated prenatal screening and diagnostic testing options that provide women with previously unavailable pregnancy information. Table 9.1. The primary objective of prenatal screening and diagnosis is to detect genetic disorders or abnormalities that could affect the woman, fetus, and newborn. Screening versus diagnostic testing. There are two categories of testing, screening and diagnostic. Screening detects or identifies individuals who are at risk for an abnormality or disease. The test is performed by drawing blood at certain time frames within the pregnancy. Single screening tests described in Table 9.1 include first trimester screening, FTS, triple screen, quadruplet, quad screen, and cell-free DNA, cfDNA. Some screening tests combine portions of single screening tests. These are referred to as an integrated and sequential screening. Along with drawing blood, the use of ultrasound may be used to assist in calculating the results of the screening test. Most prenatal screening tests look for only a few specific conditions. One limitation of screening tests is the risk of false negative and false positive results, because no screening test is 100% accurate. A false negative is when the result is normal, but a chromosomal problem, such as trisomy 21, is present. A false positive occurs when there is a positive result, but the fetus is completely unaffected. Diagnostic testing is the most precise test for a given condition. These tests are typically performed after a screening test in order to provide a diagnosis. Diagnostic testing options offered during pregnancy include chorionic villus sampling, CVS, amniocentesis, and pre-implantation genetic diagnosis, PGD. Amniocentesis and CVS are more precise and usually provide yes or no answers about a condition or chromosomal abnormality. Ultrasound. Obstetric ultrasound is a procedure in which high-frequency sound waves obtain real-time images of maternal structures, placenta, amniotic fluid, and fetus during the first, second, and third trimesters. Ultrasound is also used to assist in obstetric procedures such as amniocentesis. Sound waves from an ultrasound transducer penetrate to the level of the structure being evaluated. The sound waves bounce back to a computer screen with images that are then displayed as a type of video. Ultrasound may be paused at different points so measurements can be taken or closer imaging of specific structures can be acquired. Ultrasound results are now considered to be one of the most valuable diagnostic tools in the field of obstetrics and should be readily available for members of the healthcare team. Results of ultrasound imaging is documented for each examination and placed in the woman's medical record. Ultrasound still images, and those obtained with other types of media, such as video, are then uploaded into a secure clinical or hospital system connection for storage and review for future evaluations. Patients are sometimes provided still images of the fetus, depending on each facility's policy. Ultrasound images may appear as 2D, 3D, or 4D. 2D provides a flat picture of the image because sound waves are sent straight down and reflected back, figure 9.1. 3D ultrasound provides a more advanced imaging technology, so the width, height, and depth of a structure can be visualized. This type of ultrasound also provides greater detail of typical features and assists in identifying abnormalities. Although 3D ultrasound is not considered a requirement in routine obstetrics at this time, some facilities use 3D as an adjunct to 2D ultrasound, particularly when identifying fetal facial anomalies, such as cleft lips. 4D ultrasound is similar to 3D ultrasound, but has the capability of live streaming video images. Obstetric ultrasound can be done transabdominally or transvaginally. The maternal bladder may need to be full when either approach is used in the first trimester to allow for better visualization. In the transabdominal approach, a water-soluble transmission gel or lotion is applied to the maternal abdomen as a lubricant to increase transmission of sound waves. After the gel is applied, a transducer is maneuvered back and forth across the maternal abdomen to allow visualization of multiple structures or to view a single structure from different angles. Figure 9.3. Transvaginal ultrasound requires a specially shaped transducer with a disposable probe cover containing ultrasound gel. The transducer is inserted into the vagina to create sharper images. Transvaginal ultrasound is commonly used in the first trimester for determining gestational age, but is sometimes used for later cervical length measurements and to produce clearer images of placental location. The three categories of obstetric ultrasound are standard or basic, limited, and specialized, detailed, or target. Basic obstetric ultrasound provides the following information: maternal anatomy, cervix, uterus, adnexa, number of fetuses, biometry, fetal measurements of specific structures that estimate gestational age and fetal weight or determines whether a structure is normal or abnormal size, survey of fetal anatomy, fetal presentation, presence of fetal cardiac activity, placental location, amniotic fluid volume. Limited obstetric ultrasound provides information about a specific problem or concern that requires further evaluation. These are usually done in women who have already completed a basic obstetric ultrasound. An example of a limited ultrasound is confirmation of the presence of a fetal four-chamber heart when a woman is morbidly obese. The basic examination may have had inadequate views of the fetal heart because excess adipose tissue decreases the ability of sound waves to penetrate to the structure's level. The patient is asked to come back in 2 to 4 weeks for a limited ultrasound to ensure 4 chambers are visualized. Specialized obstetric ultrasounds are performed when a specific fetal structure or organ system requires more detailed imaging than the basic examination. This type of targeted ultrasound is performed by specially trained staff, such as maternal fetal medicine physicians. Examples of indications for detailed obstetric ultrasound include the following: suspected or known fetal structure anomaly, e.g. gastroschisis. Suspected or known fetal genetic or chromosomal abnormality, e.g. trisomy 13. History of previous pregnancy with amniotic, genetic, or chromosomal abnormality. Fetal growth abnormalities, growth restriction, or macrosomia. Maternal fetal complications that affect the fetus, e.g. Rh sensitization. Non-medical obstetric ultrasound. In recent years, 3D and 4D ultrasound have been used in non-medical locations for patient entertainment pictures and videos, especially in the identification of fetal gender. Although ultrasound has been used for many years and has been part of numerous research studies, ultrasound technology involves the delivery of sound waves that cannot be assumed to be harmless. There is a possibility, though small, that effects from these sound waves may have a biologic impact on the fetus. Ultrasound for non-diagnostic purposes by non-credentialed personnel have been criticized by multiple professional organizations. Concerns about these ultrasounds include theoretical adverse bioeffects of ultrasound, false reassurance to women because subtle abnormalities may be missed, and identification of abnormalities in a location where staff is not knowledgeable enough to discuss the abnormality or provide follow-up appointments. Non-medical use of ultrasound is considered inappropriate and should not be used in obstetric practice. Obstetric ultrasound, while considered safe, should be used for medical and obstetric reasons only. Patient reactions to obstetric ultrasound. Most women in the United States have at least one ultrasound examination during pregnancy. Many women expect and often look forward to an ultrasound at some time during pregnancy. Ultrasound is often done with the first prenatal visit to confirm the pregnancy, and the EDD determined by the woman's last menstrual period, LMP. Parental responses to ultrasonography vary widely. Some women are excited and report feelings of love and protectiveness when the fetus is visualized. Ultrasound may help women establish an early relationship with the pregnancy that will assist with maternal-newborn bonding in the postpartum period. Others report anxiety, fear, or concern that something will be wrong. Sometimes an unexpected occurrence of an abnormality fails to give women the reassurance they were expecting. Women may not be sure how to manage an abnormal result. Some respond by gathering more information from the healthcare team before making pregnancy management decisions that may be difficult. Fetal genitalia are differentiated as male or female by the 12th week of gestation. The gender may be determined during an ultrasound after this time. Many couples expect to know the gender of their fetus. Others do not want to know, even if it is obvious, and prefer to wait and be surprised. The parents' desires should be respected in this matter. The sonographer often provides the parents with still images as keepsakes. First trimester ultrasonography. During the first trimester, transvaginal ultrasonography allows clear visualization of the uterus, gestational sac, embryo, and pelvic structures such as the ovaries and fallopian tubes. Purposes. During the first trimester, ultrasonography is most frequently used to do the following: confirm pregnancy, verify the location of the pregnancy, e.g. uterine, ectopic, identify multifetal gestations, determine gestational age with measures such as crown rump length, CRL, and head measurements, confirm number and viability of fetuses, identify markers such as knuckle translucency, NT, which suggests chromosome abnormalities, determine the locations of the uterus, cervix, and placenta. An embryo can be seen approximately 5 to 6 weeks after the LMP. At this time, the CRL of the embryo is the most reliable measure of gestational age. Fetal viability is confirmed by observation of fetal heartbeat, which is visible when the CRL of the embryo is 5 millimeters. Procedure. The woman is placed in a lithotomy position for transvaginal ultrasound. A transvaginal probe, encased in a disposable cover and coated with a gel that provides lubrication and promotes conductivity, is inserted into the vagina. The procedure takes approximately 10 to 15 minutes to complete. Second trimester and third trimester ultrasonography. Transabdominal ultrasonography is most often used during the second and third trimesters because the uterus extends out of the pelvis, allowing clear view of the fetus and placenta. Purposes. Ultrasonography is used throughout the second and third trimesters for the following: confirm fetal viability, evaluate fetal anatomy, including the umbilical cord, its vessels, and the insertion site, determine gestational age, assess serial fetal growth over several scans, Evaluate quantity of fluid. Compare fetal growth and amniotic fluid volumes in multifetal gestations. Evaluate 4 or 5 markers in a biophysical profile, BPP. Locate the placenta when placenta previa, abnormal implantation of the placenta in the lower uterus, is suspected. Determine fetal presentation. Gestational age determination with ultrasonography is increasingly less accurate after the first trimester because the combination of individual growth potential and intrauterine environment causes greater variations among fetuses. The following two methods improve the accuracy of gestational age determination in later pregnancy. Multiple measurements are calculated from measurements of the fetal head biparietal diameter, head circumference, abdominal circumference, the length of bones in the extremities. If the woman is between 24 and 32 weeks of gestation, 2 or 3 ultrasound measurements may be taken 2 weeks apart to compare against standard fetal growth curves. If measurements are done after 32 weeks of gestation, fetal age is subject to error. Procedure. For transabdominal ultrasound, the woman is positioned on her back, with head and knees supported. Her hip may be wedged to either the left or right side with a pillow to prevent aortocaval syndrome from the gravid uterus. Warm transmission gel is spread over the abdomen, and the sonographer slowly moves the transducer over the abdomen to obtain the picture. See Figure 9.3. The procedure takes 10 to 30 minutes. Prenatal screening tests. First trimester screening. In the first trimester, screening tests incorporate maternal serum results with ultrasound examinations. Fetal ultrasound is a valuable tool in the first trimester in identifying aneuploidies and structural abnormalities. First trimester screening, FTS, includes knuckle translucency NT measurement via ultrasound with maternal serum analyte quantification of pregnancy-associated plasma protein A, PAP-A, and human chorionic gonadotropin, HCG. FTS screens for trisomy 21 and trisomy 18 NT is a first trimester ultrasound measurement of the fluid-filled space measurement at the back of the fetal neck. Figure 9.4. This measurement can be obtained when a fetal crown rump length is performed for gestational age dating. An enlarged NT, often defined as 3.0 millimeters or greater, or above the 99th percentile for gestational age, is associated with trisomy 21 as well as structural abnormalities such as congenital heart defects. Human chorionic gonadotropin, HCG, is a hormone produced by the embryo. The level in the mother's blood usually doubles every 2 days for the first 4 weeks of pregnancy, peaking at 8 to 10 weeks, and then declines for the remainder of the pregnancy. Increased levels of maternal serum, HCG, have been associated with trisomy 21, whereas trisomy 13 and 18 demonstrate decreased levels. PAP-A is a glycoprotein made by the placenta and is released directly into the maternal bloodstream. This protein is detectable in maternal serum at approximately 6 weeks of gestation and peaks at 14 weeks of gestation. Low first trimester PAP-A maternal serum levels are linked to trisomy 21. An independent ultrasound marker that is sometimes used in addition to FTS is nasal bone assessment. Assessment of the fetal nasal bone is sometimes used in first trimester detection of trisomy 21. One characteristic feature that is often found in individuals with trisomy 21 is mid-face hypoplasia and a flattened nose. In obstetric ultrasound, at 11 to 14 weeks, the nasal bone may not be visible. The presence or absence of a visible nasal bone is an important ultrasound finding. Unfortunately, this type of imaging is technically difficult and has not been shown to improve trisomy 21 prediction when combined with FTS or NT. Cell-free fetal DNA. Advances in genomics have resulted in the development of cell-free DNA, cfDNA, screening in obstetrics, as well as other fields such as oncology. In obstetrics, small fragments of cfDNA originating from maternal and fetal cell breakdown at the placental level mix freely in maternal circulation. cfDNA is found in maternal serum as early as 5 to 7 weeks of gestation, becomes a more suitable source of fetal genetic material after 10 weeks of gestation, and then dissipates shortly after delivery. This type of screening, sometimes referred to as non-invasive prenatal screening, is a maternal serum screening test that targets trisomy 21, trisomy 18, trisomy 13, sex chromosome composition, and selected microdeletions and microduplications. However, approximately 10% of cfDNA disseminated in maternal circulation is of fetal origin, with the remainder being of maternal origin. This makes analysis of cfDNA challenging because the test cannot distinguish between fetal and maternal DNA, leading to false results. Neural tube defects, NTDs, cannot be identified with cfDNA. At this time, cfDNA is just one of many screening options for aneuploidies and is not a primary prenatal screening test. Initially, cfDNA screening in the obstetric population was designed for high-risk patients, including maternal age 35 years or older at delivery, or ultrasound findings indicating an increased risk for an aneuploidy. The screening test was found to have high sensitivity and specificity for trisomy 21 in this population. Sensitivity means that if the test result is negative, trisomy 21 is unlikely in the pregnancy. If cfDNA screening is positive and the test is highly specific, trisomy 21 is probably present. Subsequently, cfDNA screening is now offered to women at both low and high risk. Unfortunately, there does appear to be a larger proportion of false positive tests among low-risk patients compared with high-risk women. The test can be performed at approximately 10 weeks and has no gestational age cutoff. Results are returned within 1 week. All women with a positive screening result should have diagnostic testing such as CBS or amniocentesis offered for diagnosis confirmation. Second trimester multiple marker screening. Second trimester multiple marker screening reports a woman's risk for trisomy 21, trisomy 18, and open NTDs, e.g. spina bifida and anencephaly. This screening method requires maternal serum to be drawn so specific maternal serum analytes can be measured. Screening is performed between 15:07 and 22:67 weeks of gestation, but is optimal between 16 and 18 weeks to improve screening for open NTDs. Maternal analytes include 1. HCG, 2. alpha-fetoprotein, AFP, 3. inhibin A, and 4. unconjugated estriol, UE3. These hormones and proteins are produced by the fetus or the placenta and cross over into maternal circulation. Triple screens measure HCG, AFP, and UE3 levels. Quad screens determine the level of all 4 analytes. Results are based on computer risk calculations of the serum analyte levels, gestational age, maternal weight, ethnicity, presence of diabetes, and number of fetuses. Incorrect information, such as gestational age, entered into the computer will decrease result accuracy, which can delay future testing options. Accurate maternal weight is obtained at the time of the blood sample. The obese woman may have an inaccurate low AFP with serum dilution, whereas thin women may have inaccurate elevation. Women with type 1 diabetes have a greater risk for a fetus with an NTD, but have a lower AFP level. Black women have a lower risk for a fetus with an NTD, but have a higher AFP level than other ethnic groups. All results are reported as negative or positive. AFP is a glycoprotein that is produced early in the first trimester in the yolk sac and eventually from the fetal gastrointestinal system. This protein is transported from fetal plasma into fetal urine, which is then excreted into amniotic fluid. Although a portion of AFP is swallowed and digested by the fetus, the remainder crosses fetal membranes through diffusion into maternal circulation. Levels increase until 10 to 14 weeks and then decline. Low levels of AFP suggest chromosomal trisomies such as trisomy 21, gestational trophoblastic disease, a normal fetus with overestimation of gestational age or increased maternal weight. Levels that remain elevated are most commonly associated with NTDs. Other circumstances associated with elevated AFP include the following: underestimation of gestational age, undiagnosed multiple gestation, fetal demise, conditions associated with fetal edema such as cystic hygroma, other anomalies, specifically abdominal wall defects, such as gastroschisis. NTDs are congenital anomalies affecting the brain and spinal cord. Different types of NTDs can occur, and each has a different level of severity. Two of the more common types of NTDs are anencephaly and spina bifida. Anencephaly is abnormal development of the brain and skull affecting brain function and is severe enough to result in fetal or neonatal death. In spina bifida, including meningocele and myelomeningocele, extensive nerve damage can be expected. In meningocele, the meninges protrude from the spinal canal, and in myelomeningocele, spinal cord and meninges protrude through the defect. Complications of spina bifida include a range of minor physical disabilities with little function impairment to severe physical and intellectual disabilities requiring specialized care and equipment. Spina bifida occulta is not an open NTD and may cause no problems. Open NTDs are fairly common. However, since the introduction of folic acid to food products and additional supplementation in prenatal vitamins, the rate of NTDs has decreased. UE3 is made by the fetal liver and placenta. Levels of this protein rise through the pregnancy. Trisomies 18 and 21 are associated with lower levels of UE3. Inhibin A is another glycoprotein that originates in the placenta. Levels of this protein gradually rise through pregnancy. Levels of inhibin A that are 2 times higher than normal are associated with trisomy 21. Combined first and second trimester screening tests allow for a higher detection rate than FTS alone. This means that second trimester screening tests can be joined with components of FTS. Integrated screening combines NT measurement and PAP-A with a quad screen. The first portion of this test is done between 11 and 13 weeks, followed by the second portion between 15 and 22 weeks of gestation. The sequential stepwise screening combines NT measurement, HCG, and PAP-A with results from the quad screen. Serum integrated screening combines PAP-A results with the quad screen, but NT measurement is omitted. Results for integrated, sequential stepwise, and serum integrated screening are not available until the second trimester. Prenatal diagnostic tests. Chorionic villus sampling. A disadvantage of second trimester screening and diagnostic testing is the delay in obtaining results. This can lead to a prolonged interval between screening and diagnosis, which may have an impact on the pregnancy decision-making process. Additionally, delaying diagnostic procedures until the second trimester, when maternal perception of fetal movement is more pronounced, may cause increased emotional stress for the woman. As a result, first trimester CVS allows for more immediate results early in pregnancy compared with other diagnostic testing options, such as amniocentesis. Chorionic villi are microscopic projections that develop from the chorion and burrow into the endometrial tissue during placental formation. Chorionic villi are located in the placenta's intervillous space. These finger-like projections maximize contact with surface area that is exposed to maternal circulation for nutrient and gas exchange. Additionally, chorionic villi typically contain the chromosomal, metabolic, and genetic material makeup of the fetus. CVS is normally performed between 10 and 13 weeks of gestation to diagnose fetal chromosomal, metabolic, or deoxyribonucleic acid abnormalities. Two approaches for aspiration of placental tissue can be used, transcervical or transabdominal. Both require ultrasound examination to confirm FHR, gestational age, and location of the uterus, cervix, and placenta. Either approach is acceptable. However, patient choice and technical difficulty, based on a variety of situations, are often considered when deciding between either approach. For example, the transabdominal approach may be used in women who have active herpes to avoid transmission to the fetus. Final CVS results can be reported in 5 to 7 days. Patients can be provided reassurance when results are normal. If abnormal results are detected, the healthcare provider will discuss pregnancy management options with the woman that may include continuing the pregnancy or pregnancy termination. If chosen, pregnancy termination is generally safer for women at an early gestational age. When time is a factor, a technique called fluorescence in situ hybridization, FISH, may be used for chromosome analysis. FISH offers an opportunity for rapid screening of aneuploidies, resulting in turnaround time 24 to 48 hours. Unfortunately, FISH is not diagnostic because the test is unable to detect other chromosomal abnormalities such as structural rearrangements. Women should wait for final CVS results before making decisions about pregnancy management. Procedure. As with all diagnostic procedures, the woman should receive counseling about the procedure itself, as well as genetic counseling about the specific defect for which CVS sampling is being performed. The risks and benefits of the procedure should be carefully explained, and a signed informed consent should be obtained. Transcervical villus sampling is performed by inserting a flexible catheter through the cervix, figure 9.5. The transabdominal approach is performed using an 18 or 20 gauge spiral needle with a stylet attached. Both procedures require the insertion site be aseptically prepared. Ultrasound is used to guide the catheter or needle placement. A sample of chorionic villi, usually between 10 and 30 ml, is aspirated into a syringe containing culture medium. If an insufficient sample is obtained, a second aspiration may be needed. RhoGAM is administered to Rh-negative women after CVS to prevent alloimmunization, formerly referred to as isoimmunization. Alloimmunization is a maternal immune system response to foreign red blood cell surface antigens produced by the fetus. RhoGAM can assist in suppressing the immune system to avoid fetal risks for hemolytic diseases such as hydrops fetalis. Women are often concerned about CVS procedure safety and pregnancy loss risk. There are varying opinions and research studies about pregnancy loss rates with CVS. In general, if CVS is accomplished by experienced, specifically trained physicians who perform a large volume of CVS procedures, the pregnancy loss rate is less than 1%. Limb reduction defects were once associated with CVS when the procedure was performed at less than 10 weeks gestation. Improvements in technique and timing of procedure shows no increased risk for this type of defect when CVS is performed at 10 weeks or greater. Minimal risk between 8 and 9 weeks of gestation, and approximately 1% at less than 8 weeks. Other CVS complications include culture failure rate in growing chromosomes, subchorionic hematomas, infection, and spontaneous rupture of membranes. The most common patient complaint after CVS is post-procedure spotting that appears red in the first 2 days and transitions to brown. Spotting occurs in up to 32% of women who had transcervical CVS procedures, and less frequently with transabdominal approaches. Spotting generally resolves without intervention. Uterine cramping is normal the day of the procedure. Post-procedure recommendation includes resting for 24 hours and avoiding exercise, heavy lifting, and sexual intercourse for several days. All women should receive written and verbal instruction to report signs of heavy bleeding, clot or tissue passage, leakage of amniotic fluid, or temperature greater than 100.4 degrees Fahrenheit. Amniocentesis. Amniocentesis is an invasive procedure that has been the foundation of prenatal diagnosis for many years. The procedure involves aspiration of amniotic fluid from the uterus, figure 9.6. Amniocentesis is performed for a variety of indications and at different gestational ages. Common indications for amniocentesis include identifying chromosomal, metabolic, or genetic abnormalities. Amniocentesis can assist in determining fetal lung maturity (FLM) status. Less common indications for amniocentesis include identification of fetal infection and therapeutic amniocentesis for amniotic fluid volume disorders such as hydramnios and oligohydramnios. Amniocentesis for severe hemolytic disease is no longer part of clinical practice. This has been replaced by less invasive techniques such as Doppler flow studies. Procedure. Ultrasound is used to locate the fetus, placenta, and pockets of amniotic fluid. These pockets of fluid should be large enough to allow a needle to be advanced and generally should be free of fetal body parts and umbilical cord. The abdomen is prepared aseptically. A small amount of local anesthetic is sometimes injected subcutaneously into the skin for patient comfort, but women will still feel pressure and cramping as the needle enters the myometrium. A 20 to 22 gauge spinal needle with stylet is inserted into the fluid pocket. A syringe is then attached to the needle to allow for aspiration of 1 to 2 milliliters of amniotic fluid. The syringe is immediately discarded to prevent maternal cell contamination when fluid is sent for analysis. Another syringe is then connected, and approximately 20 milliliters or more of fluid is removed for examination. The amount removed is determined by the number of required diagnostic tests. Fetal cardiac activity and fetal movement is documented post-procedure in mid-trimester amniocentesis. For later gestational ages, electronic fetal monitoring may be implemented to monitor FHR and contraction pattern if the fetus is considered viable. RhoGAM is also administered to Rh-negative women to prevent hemolytic disease in the fetus or newborn. Pregnancy loss is another concern for women after amniocentesis. Like CVS, accurate data reflecting pregnancy loss rates vary, but most agree that the rate has decreased over the years because of better ultrasound equipment and procedure technique. Presently, pregnancy loss rate is quoted as less than 1% in facilities where experienced physicians perform frequent amniocentesis procedures. Women may experience vaginal spotting or continuous leakage of amniotic fluid, which occurs in 1% to 2% of procedures. Unlike spontaneous preterm premature rupture of membranes, which can occur because of infection, vaginal bleeding, or uterine distension, rupture of membranes after amniocentesis is often short-lived and not usually associated with adverse perinatal and neonatal outcomes. Incidences of needle injuries to the fetus and maternal infection are extremely rare. Patient complaints are similar to those with CVS. Women may verbalize post-procedure uterine cramping that may last several hours. Some women experience low abdominal discomfort that can last 24 to 48 hours. Women may notice a small amount of amniotic fluid leakage the first day. This is associated with the needle puncture site between the uterus and amniotic membrane that usually reseals quickly. Post-procedure patient instructions include resting the day of the amniocentesis and resumption of normal activities the next day. Women should be instructed to report signs of bleeding, amniotic fluid that continues to leak after 24 hours, severe cramping that lasts several hours, or a temperature greater than 100.4 degrees Fahrenheit. Amniocentesis for prenatal diagnosis. Amniocentesis for prenatal diagnosis is usually performed mid-trimester, between 15 and 20 weeks of gestation, when an adequate amount of amniotic fluid and viable fetal cells are available for chromosomal, genetic, and metabolic evaluation. The biggest disadvantage of performing amniocentesis for prenatal diagnosis is that final test results are not available for a minimum of 10 to 14 days. Longer periods of time are required than with CVS for fluid analysis and cell growth. FISH testing also may be used, but similar to CVS, results are interpreted only as preliminary findings. Another disadvantage of amniocentesis is the procedure takes place in the second trimester, when the pregnancy is more apparent and fetal movement has been perceived. The maternal bonding process has started, making decisions about pregnancy continuation versus termination more emotionally and physically difficult. Early amniocentesis before 15 weeks of gestation has been mostly abandoned in clinical practice for a variety of reasons. These include the following. 1. Increased degree of difficulty because of incomplete fusion of the amnion and chorion early in the pregnancy. This results in membrane tenting, causing the needle to be unable to penetrate the membranes and resulting in a higher failed procedure rate. 2. Problems obtaining an adequate amount of fluid for sampling because the amount of amniotic fluid is less at early gestational ages. 3. Increased rates of pregnancy loss and amniotic fluid leakage has been linked to Talipes equinovarus, clubfoot. The incidence of this deformity is approximately 1.3% compared with 0.1% mid-trimester and is believed to occur as a result of disrupted amniotic membranes and amniotic fluid leakage. Amniocentesis to determine fetal lung maturity. One of the last systems to mature structurally and physiologically in the fetus is the pulmonary system. One complex substance, surfactant, plays an important role in fetal lung maturation, FLM. Surfactant is primarily composed of phospholipids. Surfactant has many functions, but primarily reduces surface tension on the inner walls of the alveoli, allowing them to stay slightly open during exhalation. Additionally, surfactant stabilizes lung volume, alters lung mechanics, and maintains gas exchange in the lung. Without adequate surfactant, lung walls adhere to one another, making alveoli inflation during inhalation difficult, which in turn increases the amount of pressure required to keep alveoli open. If this situation is not corrected, impaired oxygenation eventually leads to respiratory distress syndrome, RDS, and other neonatal complications, increasing the rates of neonatal morbidity and mortality. Consequently, evaluation of FLM may be indicated to reduce neonatal complications. Primary laboratory methods of evaluating FLM are using the lecithin to sphingomyelin LS ratio, presence or absence of phosphatidyglycerol, PG, and lamellar body counting. Visual inspection of amniotic fluid can provide preliminary results. Amniocentesis for FLM is often performed to prevent iatrogenic preterm birth. For instance, a woman may present to an obstetric clinic with no prior prenatal care, a fundal height of 36 centimeters, and a history of 2 prior classic cesarean births. Ultrasound biometry to determine gestational age and weight at term can be off as much as 3 to 4 weeks. If FLM testing is performed in this situation and the results demonstrate mature fetal lungs, this decreases the concern for neonatal respiratory complications. Repeat cesarean birth then can be scheduled. Amniocentesis is required to prevent iatrogenic preterm birth in women who request to deliver before 39 weeks for non-medical indications. For example, a grand multiparous patient lives 45 minutes from the nearest hospital and is due in January during peak blizzard season. She requests to be delivered at 38 weeks for logistic reasons because the 3 preceding labors were less than 1 hour. The last delivery required aggressive postpartum hemorrhage management, including blood transfusions, and she is able to arrange for childcare during that time. Although non-medically indicated induction is seriously discouraged by professional organizations because of adverse neonatal outcomes in the early term period, amniocentesis may be performed to ensure FLM before scheduling an induction date. Finally, amniocentesis can guide clinical decision management about maternal fetal risks for pregnancy continuation over maternal fetal risks associated with preterm birth are being considered. I've read that sentence about 4 times now, and it still doesn't make sense to me, but that's all right. This may be the case for a person with type 1 diabetes at 37 weeks who is experiencing new onset extreme fluctuations in blood sugar results. If the FLM is mature, early delivery may decrease the risk for stillbirth. Nurses should have a clear understanding of what each FLM test is evaluating. Lecithin is a phospholipid component of fetal lung fluid and surfactant. Concentrations of lecithin gradually increase throughout pregnancy and peak at 34 to 35 weeks of gestation. Sphingomyelin is an amniotic membrane lipid with a relatively stable concentration in amniotic fluid during the entire pregnancy. By 35 weeks, lecithin concentration over sphingomyelin increases markedly, with a LS ratio changing from 1:1 to 2:1. A ratio of 2:1 or greater of lecithin to sphingomyelin generally indicates adequate surfactant and mature fetal lungs. In some situations, such as maternal diabetes, a LS ratio of 2:1 may not indicate fetal lung maturity, and additional testing is necessary. Another component of surfactant that can be evaluated for FLM is establishing the presence of PG. Presence of PG supports the likelihood that fetal lungs are mature. PG testing may be useful in preterm premature rupture of membranes when amniotic fluid can be collected from vaginal pooling. Although fluid obtained this way may be contaminated by mucus, blood, or bacteria, which may interfere with the accuracy of the test. LS ratio in PG testing can be affected by the presence of maternal or fetal blood and meconium in amniotic fluid that has been obtained by amniocentesis. Lamellar bodies are the storage form of surfactant produced by type 2 pneumocytes, figure 9.7. Counting lamellar bodies is another method of evaluating FLM. This test uses a hematology analyzer, which is used for platelet counting to evaluate 1 milliliter of amniotic fluid, and takes approximately 15 minutes to complete. This test is more objective, is less labor-intensive, does not require a special technique to perform, and is less expensive than other testing options. A count greater than 30,000 to 55,000 per microliter is highly predictive of FLM. Counts below 10,000 to 15,000 per microliter suggest fetal lung immaturity, putting that neonate at significant risk for RDS. Visual inspection of amniotic fluid for color and particles can offer information about surfactant levels before amniotic fluid is sent to the laboratory for analysis. Amniotic fluid is yellow and clear in the first and second trimesters. In the third trimester, amniotic fluid becomes colorless. By 35 weeks of gestation, amniotic fluid is cloudy with particles of vernix appearing by 36 to 37 weeks of gestation. Generally, amniotic fluid with obvious vernix or cloudy fluid that does not permit the reading of newsprint through the specimen tube is considered a mature LS ratio. The foam stability test is another visual aid which is not used as frequently. This test is based on surfactant's capability to generate a foam ring around the inside of a glass tube when ethanol is added. Ethanol eliminates the effect of non-surfactant factors on foam formation. After the mixture is shaken for approximately 15 seconds, a stable foam ring will form if surfactant is present. Holy F sounds, Batman. Percutaneous umbilical blood sampling. Percutaneous umbilical blood sampling, PUBS, also referred to as chordocentesis, is a diagnostic procedure typically performed after 18 weeks of gestation. This procedure is similar to amniocentesis, but requires fetal blood to be drawn from the umbilical cord through the maternal abdomen. A spinal needle, usually 21 or 22 gauge, is inserted via ultrasound guidance into the umbilical vein. The umbilical vein is preferred over other locations because this vessel is larger and less likely to cause complications, such as fetal bradycardia or bleeding. Other complications include umbilical cord laceration, umbilical cord hematoma, thrombosis, infection, preterm labor resulting in an emergent preterm delivery of a compromised fetus, preterm premature rupture of membranes, and pregnancy loss. PUBS has been used to obtain fetal chromosomes, manage fetal hemolytic disease, and confirm congenital infections such as cytomegalovirus. Although PUBS is used in some high-risk centers on a case-by-case basis, there may be alternatives such as CVS, amniocentesis, or Doppler flow studies that are safer, easier, and faster. Pre-implantation genetic diagnosis. Pre-implantation genetic diagnosis, PGD, is a testing option that is available only to patients undergoing in vitro fertilization. PGD analyzes one or more cells from an embryo between days 3 and 7 after fertilization. PGD looks for specific genetic conditions that may be inherited from one or both parents who are known carriers, such as sickle cell anemia and Tay-Sachs disease. Results are usually received within 1 to 2 days. PGD is not as reliable as CVS or amniocentesis because cells are obtained from an early embryo, so further diagnostic testing is recommended to validate a diagnosis. Who should be offered prenatal screening and diagnosis? Prenatal screening and/or diagnosis is offered to all women who desire to be tested in pregnancy regardless of maternal age, family history, or obstetric history. Testing for underlying maternal medical conditions, e.g. diabetes, or exposure to environmental toxins may be suggested to patients. All prenatal tests are voluntary, but not all women choose to participate in prenatal testing options. Each woman has a choice on whether testing will be pursued. Unbiased, non-directive counseling about benefits and limitations of each test, as well as informed patient consent, should be provided before testing. Women who receive well-informed counseling about prenatal testing options are more likely to decline prenatal testing. This is a reflection that women feel enabled to make informed prenatal decisions. Women are advised that there is no right or wrong answer when making decisions to pursue prenatal screening and diagnosis. Many women make decisions based on personal beliefs, values, traditions, and culture. Decisions also may be made with assistance from a spouse or a significant other, family members, friends, religious affiliations, establishments, or trusted healthcare providers. Several questions are often asked during the education and counseling process. 1. Why do you want this information? Prenatal screening and diagnostic testing can offer vital information to women and healthcare providers on pregnancy options through shared decision-making process. For some patients, a normal result can provide reassurance. On the other hand, waiting for results can impart fear, anxiety, and concern. 2. What will you do with the results? If a screening test is positive, the patient has options to pursue more testing or decline anything further until after delivery. This can heighten anxiety for the remainder of the pregnancy. If diagnostic testing shows an abnormal result, this knowledge may give women and their families time to learn about the disorder, allow for referrals to specialists of the identified disorder, and seek information about the infant's future medical care. Alternatively, women can choose to terminate the pregnancy. 3. Will test results influence prenatal management? Some prenatal tests detect structural anomalies such as myelomeningocele spina bifida may be surgically repaired in utero. Screening and diagnosis may identify a condition such as a congenital heart defect that will require delivery at a specialized facility with immediate evaluation and treatment at the time of birth. Nursing role in prenatal screening and diagnosis. In addition to physicians and genetic counselors, nurses play an important role in prenatal testing. Nurses are one of the patient's main resources of electronic and written information. Nurses often assist women in understanding available testing options and answer questions. Nurses sometimes help schedule tests and assist physicians with the more invasive procedures. Finally, nurses are a key source of emotional support to women and their families. Antepartum fetal testing. Fetal well-being may need to be assessed more frequently during the antepartum period, especially with a viable gestational age in a high-risk pregnancy. Table 9.2. The primary goal of antepartum fetal testing is identification of fetuses at risk for permanent neurologic injury or stillbirth, so timely intervention can be done to decrease perinatal morbidity and mortality rates. Nevertheless, despite widespread use of antepartum fetal testing, there continues to be inadequate evidence to demonstrate an improvement in perinatal outcome except for fetal Doppler flow ultrasound. Antepartum surveillance methods are selected based on the maternal fetal risk factors, gestational age, and available technology. Common methods of fetal surveillance include the following. 1. Fetal movement counting, FMC. 2. Non-stress test, NST. 3. Contraction stress test, CST. 4. Biophysical profile, BPP. 5. Modified biophysical profile, MBPP. 6. Doppler flow studies. All of these methods are considered screening tests, and none are considered better than the other. Each one offers a different endpoint that is considered in the clinical decision-making process. Nevertheless, like all screening tests, a false negative rate or false positive rate is possible. In most situations, normal antepartum fetal testing results are encouraging, as reflected in the low false negative rate for surveillance tests. False negative in antepartum fetal testing is defined as a stillbirth occurring within 1 week of a normal antepartum fetal test result. In some cases, when an abnormal test result is obtained, the test is more likely to indicate a false positive, which means the antepartum test is abnormal, but an unaffected fetus is delivered. True positives occur when an abnormal result corresponds with a compromised fetus at delivery. No test can predict stillbirths related to acute unpreventable circumstances such as umbilical cord prolapse. Similar to prenatal screening and diagnostic tests, the nurse provides an appropriate level of patient education based on the obstetric situation. Tools such as educational pamphlets covering antepartum surveillance can reinforce key points of the maternal fetal indication and method of assessment. Risk identification. Several risk factors have an obvious connection to fetal compromise or stillbirth because there is a presumed alteration in the maternal fetal oxygenation pathway. Briefly, oxygen is carried from the environment to the fetus along a pathway that includes the maternal lungs, heart, vasculature, uterus, placenta, and umbilical cord, figure 9.8. Interruptions can occur anywhere along this pathway. For example, severe hypertension in pregnancy can cause an oxygenation interruption at the level of the maternal vasculature, uterus, and placenta. Elevated blood pressures reduce maternal intravascular volume and cause vasoconstriction in both maternal and placental vasculature. Insufficient exchange in oxygen, carbon dioxide, nutrients, and waste products between maternal and fetal circulations may consequently lead to a fetal physiologic response, such as an elevated FHR baseline or decelerations. In some clinical situations, antepartum fetal testing may identify fetal hypoxia early enough so treatment can begin before fetal oxygenation reaches a critical level. Using the example of blood pressures in the severe range, if administration of an antihypertensive agent lowers maternal blood pressure, the process may be reversed enough to allow improved blood flow to the fetus so adequate oxygen and nutrition exchange occurs. Otherwise, if recurrent interruptions in the oxygenation pathway continue, decreased oxygen content in the blood, hypoxemia, progresses to hypoxia or decreased oxygen in fetal tissues. Anaerobic metabolism is then activated and lactic acid is produced, which can result in metabolic acidosis, metabolic acidemia, and finally potential neurologic injury or death. Other risk factors, such as maternal age and weight, are more complicated to understand because the link to neurologic injury or stillbirth is not as obvious as an interruption in the oxygenation pathway and cannot be modified. Gestational age and frequency of assessment. The gestational age to start antepartum fetal testing has not been defined. Several factors go into decisions as to when to begin testing. Antepartum fetal surveillance is traditionally initiated at 24 to 32 weeks of gestation for high-risk pregnancies. Earlier testing may be recommended for a number of reasons, including risk factors, maternal comorbidities that existed before pregnancy, and previous testing results in the current pregnancy. Experts agree that antepartum testing, especially methods using electronic fetal heart monitoring, EFM, should not be initiated until the gestational age is sufficient to expect infant survival if intervention and delivery becomes necessary. Frequency of testing is individualized to the patient and fetus, current clinical situation, and the health care team's judgment. Normally, antepartum testing is conducted weekly or biweekly. More frequent intervals of antepartum testing may be warranted if the clinical status of the woman or fetus deteriorates. For example, a woman may have biweekly NSTs and amniotic fluid index, AFI, measured for preterm gestational hypertension, but is admitted to an inpatient antepartum unit for further evaluation of worsening blood pressures. NST frequency may be increased to daily while the woman is hospitalized. Sometimes, an isolated situation warrants antepartum testing, but continued surveillance is not necessary. For example, an NST may be performed because of a patient complaint of decreased fetal movement. If the NST is reactive and the woman is reassured, no further testing is indicated. Fetal movement counting. For women, maternal perception of fetal movement has been an indicator of fetal life, and absence of movement signaled death. As a fetus becomes more hypoxic because of potential interruptions in the oxygenation pathway, activity is reduced to conserve oxygen consumption. Eventually, stillbirth may occur. Fetal movement counting, FMC, is considered a method to evaluate fetal well-being. Various counting methods for fetal movement have been suggested, but an optimal number of fetal movements or duration for counting has not been proposed. One approach to FMC is the count to 10 method. Women are instructed to rest in a quiet location and count distinct fetal movements, such as kicks or rolls. Maternal perception of 10 distinct movements in a 1 to 2 hour period is reflective of a non-hypoxic fetus at that point in time. The count is discontinued once 10 movements are perceived. Fetal movement is then recorded on paper or a cell phone application. Maternal perception of decreased fetal movement should alert a woman to seek further evaluation. Some women have difficulty recognizing fetal movement related to fetal position, obesity, amniotic fluid volume abnormalities, and placenta location. For example, an anterior placenta or a breech position may alter a woman's perception of movement. In these situations, it is sometimes useful for nurses to assist women in abdominal palpation. Rarely, women may require ultrasound to assist in distinguishing fetal movement. The time of the day can potentially influence fetal kick count results. Fetal movement generally peaks between 9 p.m. and 1 a.m., which is attributed to a fall in maternal glucose level. In this scenario, women may need to select a different time of day to perform counting. Non-stress test. NSTs involve placement of an EFM for FHR and uterine activity observation. The NST is the primary means of fetal surveillance in pregnancies at risk for uteroplacental insufficiency, inability of placenta to exchange oxygen, carbon dioxide, nutrients, and waste products properly between maternal and fetal circulations. With consequent fetal hypoxia and acidosis, the NST identifies whether an increase in the FHR occurs when the fetus moves, indicating adequate oxygenation, a healthy neural pathway from the fetal central nervous system to the fetal heart, and the ability of the fetal heart to respond to stimuli. FHR accelerations without fetal movement are also considered a reassuring sign of adequate fetal oxygenation. If the fetal heart does not accelerate with movement, however, fetal hypoxemia and acidosis are concerns. NSTs are a result of early observations, demonstrating that when normal oscillations and fluctuations in baseline FHR were present, now called variability, fetal well-being could be established. The presence of accelerations indicates intact CNS and normal autonomic regulation of the FHR, and it is predictive of the absence of fetal metabolic acidemia at the time of observation. Accelerations are defined as visually apparent increases in the FHR that reach a peak of 15 beats per minute, BPM, above the baseline, with the entire acceleration lasting a minimum of 15 seconds but less than 2 minutes. Before 32 weeks of gestation, accelerations are defined as visually apparent increases in the FHR that reach a peak of 10 beats per minute above the baseline with the entire acceleration lasting at least 10 seconds, 10 by 10. This is because preterm fetuses may not have the physiologic maturity to generate accelerations of 15 by 15. Accelerations can either be spontaneous or stimulated with fetal scalp stimulation or acoustic stimulation. Procedure. NSTs are non-invasive and can be performed in a hospital or clinic setting. Women are placed in a comfortable position, such as semi-Fowlers with a lateral tilt, to reduce the risk for aortocable compression, which may cause maternal hypotension and abnormal FHR changes. Fetal position is assessed with Leopold's maneuvers to allow correct EFM placement and maximize the ability to obtain a continuous tracing. The ultrasound transducer and toco transducer are applied and secured to the woman's abdomen to detect FHR and presence or absence of uterine contractions, figure 9.9. Although non-stress test contains the word stress, the fetus is not physically challenged by factors such as increased maternal activity or contractions to obtain necessary data. Patients remain on continuous fetal monitoring for a minimum of 20 minutes. NST can be extended another 20 minutes for a total of 40 minutes to take into account normal fetal sleep-wake cycles. Maternal ingestion of medications such as narcotics, barbiturates, benzodiazepines, or methadone, as well as alcohol, beta blockers, tobacco, and corticosteroids for FLM have also been associated with altered fetal movement. In these situations, fetal stimulation may be required to provoke a fetal response. One simple method uses an artificial larynx to provide vibroacoustic stimulation. The artificial larynx is placed on the maternal abdomen near the fetal head. Stimulation is applied for 1 to 2 seconds and can be repeated up to 3 times for progressively longer durations, 3 seconds, if no response is elicited. Fetuses will respond to externally applied sound and vibration by displaying more FHR accelerations that have increased amplitude and duration. Cell phones placed on the maternal abdomen and loud noises or vibration near the woman also may elicit a similar response. An event marker on the EFM may be pressed by the patient, recording a symbol of the FHR tracing each time movement is perceived. FHR in uterine activity is recorded on a paper tracing that comes from the EFM or an electronic tracing stored in computerized systems. Contractions not perceived by women may be identified during an NST depending on gestational age. These contractions, which are often mild on palpation and irregular, reflect normal structural and functional changes in the myometrium during pregnancy. However, if contraction frequency increases, appears to be more coordinated, or changes intensity, women should be assessed for labor, especially in preterm gestations. Interpretation. NSTs are interpreted as reactive or non-reactive. Reactive NSTs contain 2 or more FHR accelerations previously described within a 20-minute period. Documentation of accelerations in relationship to fetal movement is not required for a reactive NST. Non-reactive NSTs are defined as fewer than 2 accelerations during a 40-minute period, figure 9.11. Variable decelerations are sometimes observed in NSTs and are typically associated with umbilical cord compression. As long as these decelerations are not recurrent and last less than 30 seconds, no further intervention or monitoring is required. However, if variable decelerations become more recurrent, defined as 3 or more in 20 minutes, the patient should be monitored for an extended period of time because this type of pattern has been associated with indeterminate and abnormal FHR patterns requiring further interventions. Decelerations that persist for 1 minute or longer during an NST have been associated with increased cesarean birth rates and stillbirth. Nurses may interpret NST results if facility educational and competency requirements have been met. Contraction stress tests, CSTs, determine fetal well-being by monitoring FHR responses to contractions. A CST may be done if the NST findings are non-reactive. Usually, a BPP is performed in place of the CST. The physiologic premise behind CST is that between the uterus and placenta are a number of vessels, including uterine spiral arteries. These arteries carry oxygenated blood to the intervillous space, which contains chorionic villi. When the uterus contracts, uroplacental blood flow is temporarily interrupted as a result of blood vessel compression. In response to contractions, healthy oxygenated fetuses can physiologically tolerate contractions and maintain FHR with normal characteristics such as stable baseline rate and accelerations. In compromised fetuses, brief interruptions of oxygen transfer during contractions can result in late decelerations because the fetus is assumed to be in a state of hypoxemia. Late decelerations are defined as a gradual FHR decrease greater than or equal to 30 seconds from FHR baseline, with a nadir, lowest part of the deceleration, occurring after a contraction peaks, followed by a gradual recovery to baseline after a contraction ends. If the contraction pattern continues, the fetus could progressively deteriorate down a pathway of hypoxia, metabolic acidosis, metabolic acidemia, and potential neurologic injury. Other names for CSTs include the oxytocin challenge test, OCT, which intravenous oxytocin is used to elicit contractions, and the nipple stimulation test, in which maternal manipulation of the nipple produces contractions. Regardless of which method is used, success rates for achieving an adequate contraction pattern to interpret test results are similar. Procedure. CSTs are typically performed in a hospital environment where interventions such as administration of intravenous medication or an immediate delivery can occur in the event of an emergency. Relative contraindications for performing the test include patients in whom vaginal delivery is not recommended at the time of the test. Examples include placenta previa, preterm premature rupture of membranes, preterm labor, history of preterm delivery, previous classic cesarean section, or multiple gestations. Procedure steps are exactly the same as for an NST. Initial monitoring will determine whether at least 3 spontaneous contractions within a 10-minute time frame are present. The duration of each contraction should be 40 seconds or longer and palpable to the nurse. Contractions do not need to be painful to patients for test interpretation. If spontaneous contractions are sufficient, additional uterine stimulation is not needed. When adequate contractions are not present, oxytocin or nipple stimulation is required. An adequate contraction pattern with continuous FHR data on a tracing must be present to interpret CST results. OCTs require an intravenous infusion of dilute exogenous oxytocin to stimulate contractions. Oxytocin is administered by a continuous infusion pump per hospital policy. One sample protocol starts oxytocin at 0.5 milliunits per minute to 2 milliunits per minute, with increases every 15 minutes until sufficient contractions are recorded. Oxytocin is discontinued once an adequate contraction pattern with interpretable data is recorded. If there is evidence of tachysystole, more than 5 contractions in a 10-minute segment averaged over a 30-minute period, prolonged decelerations, recurrent variable decelerations, or recurrent late decelerations, oxytocin also should be discontinued. The alternative to oxytocin infusion is nipple stimulation. When breasts are stimulated, endogenous oxytocin is released from the posterior pituitary gland. In turn, contractions will occur. Women are asked to brush the nipple surface. One method of nipple stimulation entails 4 cycles of 2 minutes of stimulation followed by 2 to 5 minutes of inactivity. Stimulation should stop when a contraction begins. Stimulation is restarted when a contraction ends. If after 4 cycles an adequate contraction pattern is not recorded, the process should continue for another 10 minutes. If this is unsuccessful, 10 minutes of bilateral nipple stimulation should occur. Similar to OCTs, nipple stimulation is stopped when 3 or more contractions lasting longer than 40 seconds occur in a time frame of 10 minutes, or in cases of tachysystole or decelerations. The interpretation criteria for CST are as follows. Negative, no late decelerations, figure 9.12. Positive, late decelerations are present with a minimum of 50% of the contractions, even when fewer than 3 contractions occur in 10 minutes, figure 9.13. Equivocal suspicious, intermittent late decelerations or significant variable decelerations, sudden decreases in the FHR that quickly return to the baseline, figure 9.14. Equivocal FHR decelerations in the presence of contractions that are more frequent than every 2 minutes or last longer than 90 seconds, figure 9.15. Unsatisfactory, fewer than 3 contractions in 10 minutes, or a tracing that cannot be interpreted, figure 9.16. A negative CST has been consistently associated with fetal well-being, meaning the stillbirth rate is less than 1 per 1,000 as long as an acute event does not occur. Negative CSTs can be repeated in 1 week. Positive CSTs are linked to an increased incidence of fetal growth restriction, late decelerations in labor, meconium-stained fluid, low 5-minute APGAR scores, and stillbirth. The likelihood of stillbirth varies between 7% and 15%. In the event of a positive CST result, the healthcare team will discuss management options with the patient that may include further testing or an expedited delivery. An equivocal, suspicious, or unsatisfactory CST result prompts further evaluation, including repeat testing within 24 hours, prolonged continuous monitoring, or using adjunct methods of testing unless there are other clinical indications for prompt delivery. If a CST is repeated within 24 hours, approximately 7.5% of patients with an equivocal suspicious test exhibited a positive CST result, 38.8% remained suspicious, and 53.7% became negative. Biophysical profile. Biophysical profiles, BPPs, combine EFM with ultrasound assessment of specific fetal Biophysical characteristics. These include fetal movement, fetal tone, fetal breathing movement, and amniotic fluid amount. Biophysical characteristics are a reflection of the CNS and provide an indirect means of evaluating fetal oxygenation. Individual BPP components are a combination of short-term and long-term indicators of fetal well-being and sufficient oxygenation. Short-term indicators include FHR reactivity, fetal breathing movement, and fetal tone. The sole long-term indicator of adequate oxygenation is amniotic fluid amount. Each component is susceptible to oxygenation pathway interruptions that may lead to hypoxia and eventually neurologic injury if not corrected. Unlike NSTs and CSTs, which assess only FHR characteristics, biophysical scoring allows a more complete assessment of fetal growth and development, oxygenation, and uterine environment. Biophysical characteristics emerge at different stages of fetal development. Fetal tone is established at approximately 7 to 8 weeks of gestation. Spontaneous fetal movement can be observed on ultrasound at 9 weeks of gestation, starting with flexion extension of the vertebral column. Fetal breathing can be detected at 10 weeks of gestation and becomes more apparent by 19 to 20 weeks of gestation. Sometimes referred to as practice breathing, this biophysical characteristic is often rhythmic and is a reflection of diaphragmatic, laryngeal, and intercostal muscle retractions. Figure 9.17. Amniotic fluid production by the fetal renal system is present at approximately 10 weeks of gestation. Finally, FHR reactivity is established by the end of the second trimester. Oxygenation disruption that leads to acute or chronic periods of hypoxia prompts the fetus to decrease biophysical activities in reverse order of pregnancy development to preserve energy and oxygen consumption. FHR reactivity disappears first, followed by fetal breathing movement. If hypoxia continues, decreased fetal movement and loss of fetal tone will occur. During this process, levels of amniotic fluid reach critical levels defined as olighydramnios because uteroplacental circulation is not adequate to oxygenate fetal kidneys. Figure 9.18. Shunting occurs because fetuses redirect blood from areas not critical to fetal life, such as the kidneys, gastrointestinal tract, and extremities to the vital organs, which include the heart, brain, and adrenal gland. If changes in oxygenation are prolonged, blood flow to the fetal kidneys ceases. Therefore, olighydramnios in fetuses with normal renal structures and intact amniotic membranes suggests prolonged fetal hypoxia and is the strong indication of fetal compromise. Procedure and interpretation. NSTs are the EFM portion of BPPs. NSTs may be performed first to determine whether FHR is reactive or non-reactive. Sometimes the NST is not performed if ultrasound is done first and all 4 biophysical characteristics are observed. If any of the biophysical characteristics are not met, an NST will follow. Biophysical characteristics are evaluated simultaneously over a 30-minute period. This type of ultrasound is performed by sonographers, advanced practice nurses, or physicians. In some states, nurses may perform BPPs, but must attend specialized training and successfully complete competency verification. A scoring technique is used to interpret data, with each parameter receiving a score of 2, which is normal, or 0, which is abnormal. Table 9.3. Scores for all 5 BPP components are totaled together for interpretation and management. Table 9.4. BPP scores of 8 or 10 correlate with normal fetal oxygenation. A BPP score of 6 is interpreted as equivocal if there is normal fluid and suspicious for fetal asphyxia if there is abnormal fluid. In equivocal or suspicious cases, extending the testing period, retesting within 24 hours, or adding adjunct testing, such as a CST, may be done before making pregnancy management decisions. Scores of 0 to 4 in situations in which previously APFT results were normal may justify delivery of a fetus depending on the clinical scenario. Abnormal scores of 0 to 4 are usually associated with acidemia or perinatal asphyxia, which leads to poor perinatal and neonatal outcomes, including stillbirth. Modified biophysical profile. Modified biophysical profile, MBPP, is a variation of a BPP. MBPPs combine NST with ultrasound measurement of amniotic fluid. Remember, NSTs are a short-term indicator of how well a fetus is oxygenated. An amniotic fluid amount is a long-term reflection of adequate oxygenation in which shunting has not taken place. This method can be done weekly or biweekly depending on maternal fetal indication. Unlike the BPP, this test is not as time-consuming and does not require more advanced ultrasound skill. NSTs are either reactive or non-reactive. Amniotic fluid amount is assessed by measuring the largest pocket of amniotic fluid in 4 maternal abdominal quadrants. The 4 measurements are totaled together to report the AFI. Olighydramnios is considered an AFI of less than 5 centimeters in this procedure. Volume sums greater than 10 centimeters are considered reassuring. Some healthcare providers use measurement of one single deepest pocket instead of measuring 4 pockets. If a single deepest pocket is 2 centimeters or less, olighydramnios is identified. An AFI higher than 18 to 20 centimeters suggests excess amniotic fluid volume or hydramnios. Results are interpreted as normal if the NST is reactive and olighydramnios is not observed. Abnormal MBPPs are either a non-reactive NST, olighydramnios, or if both are present. Further testing is indicated if test results are abnormal. Fetal Doppler flow ultrasound. Fetal Doppler flow ultrasound is an assessment of placental condition. This non-invasive procedure assesses hemodynamic components of vascular resistance in high-risk pregnancies with fetal growth restriction. Doppler flow is also used as an alternative to detect fetal anemia when Rh alloimmunization is suspected. This method of fetal assessment measures cardiac cycle differences between peak systolic and end systolic blood flow velocity, referred to as the SD ratio, amount of blood flow resistance, and pulsatility index in various fetal vessels. Color may be added to assist in assessing blood flow velocity, figure 9.19. The most common vessels are umbilical arteries, which allow for assessment of blood flow from the fetus to the placenta. Measurements also can be taken of the middle cerebral artery, umbilical veins, and ductus venosus. More attention is being paid to middle cerebral artery measurements because of the shunting phenomenon. Again, hypoxic fetuses shunt blood flow to the brain by reducing the amount of resistance in fetal cerebrovascular vessels. This allows for an increase in blood flow to the fetal brain. Fetal Doppler flow ultrasound results are reported as normal, decreased, absent, or reversed. Fetuses that are not growth restricted may have normal high velocity diastolic flow, whereas compromised fetuses may have decreased, absent, or reversed end diastolic flow when deterioration occurs from an interruption in the oxygenation pathway. The sequence of events for abnormal Doppler flow starts with increased resistance in placental vasculature and is indicative of poor placental function. This leads to decreased diastolic velocities that eventually become absent. Once absent diastolic flow occurs, blood flow resistance continues to increase and an elastic component of fetal vasculature is added to this sequence of events. This causes reversed end diastolic flow, and the placental circulation starts to recoil or reverse after being distended. Increased resistance occurs when approximately 30% of the fetal vasculature is abnormal. Absent and reversed end diastolic Doppler images are abnormal and have been linked to altered fetal acid-base status and poor perinatal outcomes, including stillbirth. Patients with normal Doppler flow results are typically evaluated weekly. In the same week, an NST or MBPP may be requested. Increased frequency of Doppler examination and other adjuncts of fetal assessment occur when decreased, absent, or reversed flow is identified. As with other methods of APFT, Doppler results are interpreted in the context of the entire clinical scenario, including results of other surveillance methods to make pregnancy management decisions.